Good evening, everyone, and welcome to our webinar on typhoid diagnosis. As many of you may be aware, typhoid fever caused by the bacterium Salmonella typhi remains a significant global health challenge, especially in regions with inadequate sanitation and limited access to drinking water, clean drinking water. Symptoms can often be non-specific and resemble other febrile illnesses, making accurate and timely diagnosis pivotal for effective treatment and disease control. During the next 45 minutes to an hour, we will dive deep into the various diagnostic methods available, from traditional blood cultures to the more advanced molecular assays. We will evaluate their strengths, limitations, and the ideal context for their application. So, whether you're a seasoned medical professional, a budding researcher, or simply someone eager to gain a deeper understanding, our aim today is to equip you with the knowledge to better identify, understand, and potentially contribute to the field of typhoid diagnosis. Very pleased to have with us here today, Dr. Shende, consultant microbiologist working with Metropolis. He comes to us with extensive experience of over a decade and a half, maybe two, and she is the expert in this particular field of study. So without further ado, I'd like to hand over the forum to Dr. Shende. Dr. Shende, over to you, ma'am. You may start with your slideshow now.
Yeah, good evening all. Are you able to see my screen?
We're able to see your screen, ma'am, but you have to click the slideshow button.
Yeah. So good evening all. Today we are going to discuss about diagnosis of typhoid. I'll be covering these points in my presentation. Little bit about introduction of typhoid. So Pierre-Louis in 1829, he was the first. He was a French physician who coined the term typhoid. Typhoid is a word which was
Sorry to
derived
interrupt.
from Greek word.
Sorry to interrupt,
Yes.
ma'am. We are not able to see your slideshow. I can see your presentation screen, but not your slideshow. Yes. So can you click? Can you go up and click on the slideshow button? Yeah, slideshow. Yeah, play from beginning. Yeah, on the left side. Yes.
Now are you able to see?
No, ma'am. Okay. 1 second. Sorry for the little technical glitch out here. What you can do is just unshare your screen for a minute. Just stop the sharing for a minute, please. I'll just help you. Now, click the share screen button again.
Okay, sir.
And it will give you some options. You can select the presentation here. Now click. Now go on the left and say from beginning. Click on the from beginning button here.
Are you able to see now?
No, ma'am. There is some sharing rights issue on your, because yesterday when we did the trial run, it was fine. Right? It went on fine yesterday. So okay, you can do one thing. Otherwise, I'll just send you a small text email. I'll just text you. I'll just send you a test email. You can share me your PPT right now. I'll play it for you then, so that we can see the 1 second one. Please hold on. I'm sorry everybody for the glitch. Please bear with us. It'll take us a minute to sort this out. Ma'am, I've sent you a test email on your Yahoo account. You can just attach your PPT and send it to me. I'll play it for you. You can just say next. I'll keep sending the slides.
Okay, sir.
Over to you, ma'am. You can just tell me next. I'll keep changing the slide whenever you say next.
Yeah, yeah, thank you. So, good evening, all. Today we are going to discuss about diagnosis of typhoid. Next slide. I'll be covering these points in my presentation. Next slide. So, a little bit about introduction of typhoid. Pierre Louis, he was a French physician who first coined the term typhoid fever, which was derived from Greek word typhus. Typhus means smoky, which is attributed to the condition of patients, which was stupor-like. Then, in 1880, Karl Elberth identified Salmonella enterica, and it was first cultured in 1884 by George Gaffkey. There was a development of vaccine by Almoth Wright. Typhoid is still considered as a public health problem because of its serious manifestations. Case fatality rate can vary from 12 to 30% if it is left untreated. But right now we are in the antibiotic era. Because of the prompt treatment, case fatality rate can drop down to less than 1%. Typhoid is endemic in certain parts of the world, especially Asia, Africa, Latin America, and Caribbean Sea. Next slide, sir. So, how this typhoid fever develops? Next. So, for the development of typhoid fever, to initiate infection, 10 raised to 3 to 10 raised to 6 bacilli, this infective dose of the bacilli is needed. Risk factors such as decrease in the pH of stomach, prior Helicobacter pylori infection, and integrity of the intestine, or loss of integrity in the intestine due to the surgical procedures, due to certain diseases, will lead to the development of typhoid. Next. So salmonella, they have the affinity towards the epithelium of the ileum. These bacteria have the fimbriae, which help in adhering the epithelia lying the ileal, distal ileal tissue. Here, there is a lymphoid follicles, which are called as a Peyer's patches. Here, there is a proliferation of the bacilli, which leads to the hypertrophy of the Peyer's patches. Because of the intracellular communication, which is known as quorum sensing, bacteria also produce biofilm formation. Then these bacteria have the special secretory system, which is type 3 secretory system, which helps in the delivery of bacterial protein into the cytoplasm of the host cells, which is called as a bacteria mediated endocytosis. And at this particular level, the bacteria are phagocytosed by the macrophages. But bacteria keep surviving inside the macrophages, and they spread via lymphatics into the blood vessels. This is responsible for the development of primary bacteremia. After development of primary bacteremia, the bacteria disseminate through the reticuloendothelial system and the other organs, leading to the development of secondary bacteremia. Next slide, sir. So incubation period of typhoid, it ranges from 10 days to 14 days. Typhoid is usually transferred by ingestion of contaminated food or water. It is more common in young children and adolescents due to poor sanitary habits. Other risk factors which can which can lead to the development of typhoid are improper cleaning of drinking water, consumption of contaminated food. We usually see a step ladder pattern of fever, that is, there is a rise in the body temperature, but body temperature never comes back to the baseline. There are non-specific symptoms also. We can also see the rash, which is called as rose spots on the abdomen and trunk. Palpable spleen, hepatomegaly, relative bradycardia are the other features. And typhoid can also lead to the serious manifestations affecting the central nervous system, leading to the neuropsychiatric symptoms. Typhoid fever can have the complications like gastrointestinal bleeding and intestinal perforation. Next slide, sir. So the enteric fever is a broad term. Enteric fever, it includes typhoid fever by Salmonella typhi and paratyphoid fever by Salmonella paratyphi A, B, and C. Next slide, sir. So there is a state which is called as a carriers in typhoid. In inadequately or untreated individuals, there is development of the carriage. So patients continue to excrete these bacilli in the feces and the urine. Fecal carriers are more common than the urinary carriers. And depending upon the duration of shedding of bacilli, there are three types of carriers in typhoid, that is convalescent carriers, temporary carriers, and chronic carriers. Next slide. There are various diagnostic modalities by which we can diagnose typhoid. So first and most important diagnostic modality is the isolation of organisms by culture. Culture of either blood, stool or urine. Then slide agglutination testing of the colonies for the identification of serotype. Serology also plays important role. Then other laboratory tests like CBC, histopathology, and PCR based test. Next slide, sir. So the diagnosis of typhoid depends upon the collection of right specimen at the right stage of the illness. So depending upon the duration of illness, the specimen can be collected. So in the first week of illness, we can go for culture of blood, bone marrow aspirate, and duodenal aspirate. In the second week of illness, serology plays important role, especially the antibody detection by Vidal test. Then in the third week and the fourth week, stool and urine culture, they play important role. Diagnosis of carriers can be made by detection of antibodies to the VI antigen and stool and urine culture and sewage culture. Next slide, sir. So these are the general rules for collection and transportation of the specimens. You all must be well versed with these rules. Next slide, sir. So collection of blood culture. Blood culture plays important role in the diagnosis of typhoid in the first week of illness. So adequately collected blood for culture will yield the bacilli. In case of adults, we have to collect 10 to 20 ml of the blood. Paired blood culture practices is very important in case of ICU patients. In case of pediatric patients, 1 to 5 ml of the blood is sufficient. And after collection of blood culture, it should be transported to the lab as soon as possible. So these are the conventional blood culture bottles. Next. So this is the automated blood culture system. This is the Bactec machine, which will detect the growth in the blood culture bottle. This is pediatric blood culture bottle. Next, this is adult blood culture bottle. So coming to the stool culture will play important role in the third week of illness. So stool is collected in the sterile, leak-proof and wide mouth container, and stool sample is collected from the bed pan, but it should be unmixed with the urine or the disinfectants. Next slide. In case of urine culture, early morning midstream urine sample with the appropriate genital cleaning is very important. And if there is a delay in the transportation, storage of the urine at 4 degrees Celsius is mandatory. Next slide. Next. So Salmonella, they produce non-lactose fermenting colonies on the McConkey agar. On the highly selective media like Xyloslicin deoxycholate agar, they produce red colored colonies with the black center due to the production of hydrogen sulfide. These are motile gram-negative bacilli. By biochemical identification, these can be easily identified. Here are certain clues for the biochemical identification of Salmonella. They are indole negative, methyl red positive, they are citrate positive, urease negative. They produce alkaline by acid reaction on triple sugar iron agar, and the gas is produced by all the Salmonella except Salmonella typhi as it is unaerogenic. Abundant hydrogen sulfide is produced except Salmonella paratyphi A. Slide agglutination by colonies can be very important to know which serotype is infecting the humans. So diagnosis of Salmonella at the genus level can be determined by agglutination with the polyvalent O antisera, and further identification of the serotypes can be done by type specific O antisera. So Salmonella typhi agglutinates with O9 antisera, paratyphi A agglutinates with O2 antisera, and paratyphi B agglutinates with O4 antisera. Next. So these are the automations in the culture. With the help of Vitek, we can identify the organisms faster, more accurate, and also we can give the AST results. This is the closed system, so there is no chance of contamination. Depending upon the load of laboratory, 15, 30 or 60 cards per instrument can be accommodated in this Vitek 2 compact, and Vitek 2 has updated database which is compliant with the Clinical Laboratory Standard Institute guidelines. Diagnosis by culture can also be made with the help of this new technology which is called as a MIDTOF. So with the help of MIDTOF is matrix assisted laser desorption ionization time of flight detection. So after sample collection, we go for culture, and after the bacterial culture is basically exposed to the extraction method, and this particular extraction, after the extraction the matrix is applied. Here on this metal plate the colonies are applied, and then this metal plate is kept under this instrument. So with the help of laser radiation, these molecules, they get converted into the ions and they create the spectra. So this spectrum is basically identified or matched with the stored profiles or the stored database of the machine. Next slide. So this MIDI can distinguish between the related bacterial species, and it can have the improved TAT in case of slow growing organisms. MIDI has very vast database of the organisms. Next slide, sir. So diagnosis by serology is very important in case of the second week of illness. So approximately 4 to 5 ml of the venous blood is collected in the plain red topped vacuum tenor. Next slide. So this after collection, the blood is kept at room temperature for 30 minutes and without disturbing. So the serum is separated, and this serum can be used for the serological test. Next. So Vidal test, it can be done with the help of slide or tube. So it's a tube Vidal test. Next. Next. It's a slide Vidal test. So it is one of the oldest and most widely used test, and it detects the agglutination of the antibodies with the antigens. So if the antibodies are present in the patient serum, they will get agglutinated with the antigens provided in the Vidal test. Next. So O-agglutination, it is seen as a compact granular chalky clump and disc-like pattern, whereas H-agglutination, it is seen as large, loose, fluffy, cotton woolly clumps with the clear supernatant. Absence of agglutination is seen as button formation. So we can interpret the Vidal with the help of this table as if there is rise in TO and TH antibody, it is enteric fever due to Salmonella typhi. If there is rise only in the TO antibody, it is indicative of recent infection with any of the species. If there is rise only in the TH antibody, it will be due to anamnestic response or the convalescent stage. If there is rise in all the THH and BH antibodies, it is due to usually vaccination. Next. So there are certain limitations or problems with the interpretation of the Vidal test. Basically, first problem is the significant titer. Now in India, typhoid is endemic. So at what titer, which titer is called as a significant titer, it creates a problem because of prior exposure to the infection. Patients have certain amount of the antibodies in their sera which are already present. So H agglutinin titer more than 200 and O agglutinin titer more than 100 is usually taken as significant titer in most of the parts of India. Vidal have false positive test results in anamnestic response. Basically, anamnestic response is transient rise in the antibodies due to the unrelated infections. It is usually seen in the malaria and dengue in a patients who had prior exposure to the typhoid fever. False negative results also occur in the prozone phenomenon where there is excess amount of antibodies are present in patient serum. And even if the patient is on antibiotics or in the early stages of disease, we can get false negative Vidal. So interpretation on single serum sample is not at all meaningful in case of Vidal test. So we have to collect paired blood sera and fourfold rise in the second blood sample, in the second serum sample is usually meaningful in case of Vidal test. Next. Coming to the immunochromatography, it is a rapid car test for a qualitative detection of Salmonella typhi, IgM and IgG antibodies in the patient serum. It will give the results within 20 minutes. This is basically the immunochromatography, and the antigen antibody complex migrates through this nitrocellulose membrane with the help of capillary action. And when the complex meets the line of corresponding immobilized monoclonal antibody, which is coated on the nitrocellulose membrane, it is going to form a purplish pink band, which is suggestive of reactive test result. Next. Next slide. Next slide, sir. Next slide.
We were on this slide.
Slide, sir.
So you don't want, there's nothing to talk here. Limitations of immunochromatography.
Yeah. No. Next slide.
Okay. We are on biofire.
I can only see the immunochromatography here. Yeah.
Okay. Now here we have shifted. The slide has gone ahead.
Yeah.
So
Previous slides.
yeah.
So in case of immunochromatography, we have certain limitations like the diagnosis can be missed during early stages of the illness and the secondary infections. There is a cross reactivity which is seen in certain autoimmune diseases such as SLE and rheumatoid arthritis. It is only used for the screening purpose and not to be used as a single test for diagnosis. Next slide. Next slide, sir. So now we are going to deal with the PCR based test. So the PCR based tests are rapid and they are needed to start the appropriate treatment to avoid morbidity and mortality. So they provide the accurate etiological diagnosis of tropical fevers because the tropical fevers have overlapping signs and symptoms. So they provide the accurate diagnosis. Next slide. So here we collect the sample. I'll uh, I'll just speak with the sample in the next slide. So the clinical sample, approximately whole blood 3 ml is taken, and after the extraction of the nuclear material is done, and this nuclear material like DNA or RNA is subjected to real-time PCR. Next slide. So for extraction, usually the time taken is 15 minutes. And for extraction, the accepted samples are whole blood, plasma or serum, and urine samples. So these samples are to be transported at 2 to 8 degrees Celsius. And after the extraction, the real-time PCR is subjected to the elute. And for DNA viruses, the first step will be reverse transcription, and for the DNA pathogens like bacterial pathogens, the DNA is amplified for simultaneous detection of the above pathogens. So the time taken for the PCR is 120 minutes. Next slide. So the diagnostic cutoff value which is taken as less than or equal to 36. Next slide. Next.
I am on the next slide, Dr. Shende. I'm on the next slide, which is the table with the
Yeah, but I had highlighted over here. Yeah. So
okay.
as you can see, there is an amplification in the second tube and in the Texas red region, and amplification in the third tube in the FAM region, which is suggestive of Salmonella species. Next. Next slide. Next. So coming to the recent advances by PCR based method. So it is a biofire technology, biofire film array GI panel. So it is multiplex polymerase chain reaction technology. So this is a process which simultaneously detects and amplifies the nucleic acid of multiple targets in a single chemical reaction. So it isolates, amplifies, and detects the DNA of microorganisms which cause the overlapping signs and symptoms. So it is basically syndromic testing approach, and it detects 22 targets in a single test in 1 hour. So we can go for testing whenever the patients have diarrhea, dysentery, fever. Even the immunocompromised patients with the diarrhea can also be tested with this particular GI panel. So the sample is loaded into the BioFire GI panel pouch, and then the pouch is placed into this instrument, and then the run is started. So this is the BioFire instrument. Next slide. So other laboratory test, in case of complete blood count, we can see leukopenia and neutropenia. Histopathology is not often used nowadays because this intestinal perforation stage is not achieved. Because of the antibiotic era, there is a timely diagnosis and treatment of typhoid fever. So we do not tend to see the intestinal perforation due to typhoid. But if at all it is seen on ileal biopsy, we can see the oval ulcers along the long axis of the ileum. Next slide. So this is the treatment of typhoid fever. So empirical treatment means before the antibiotic susceptibility results are available. And in case of fully susceptible profile, we can use ciprofloxacin. In case of MDR strains, that is the strains which are usually resistant to chloramphenicol, cotramoxazole, and ampicillin, we can go for ciprofloxacin. In case of NAR strains, that is nalidixic acid resistant strains, nalidixic acid is a marker which is used to predict the susceptibility to the fluoroquinolones. So for such bacilli, we can go for ceftriaxone. And in case of carriers, we can use ampicillin and probenecid for 6 weeks. Next slide. So typhoid fever in India is endemic and it is of public health importance. Typhoid is under regular surveillance by Integrated Disease Surveillance Project, and they have just given this clinical case definition, like whom to call confirmed case and whom to call as a probable case. So confirmed case is any suspected or probable case, but it is lab confirmed by isolation of Salmonella typhi or paratyphi from the blood or the other clinical specimens. And if there is a fold 4 rise in the agglutination titer in a parrot sera, which is taken as 10 days apart. So, next. So, this is the end of my presentation. Thank you.
Thank you very much, Dr. Shende. That was a very insightful presentation on typhoid and its importance as a public health menace in this country. As you said, it is endemic in the country, and typhoid is also one of the oldest diseases available. You know, if we look at the growth of human population over the last few centuries, typhoid has been one of the longest diseases in existence. It's also part of what we call the AUFI, the acute undifferentiated febrile illnesses. So I was coming to your slide here, just the last one before you talked about the treatment, especially with respect to the various antibiotics available. How do you, as a diagnostician and somebody who recommends treatment, approach the fact that we're doing a lot of antibiotic treatment and then that builds up antibiotic resistance in humans as we go through, from one decade to another. So how would you recommend that we handle that part? Do we go for stronger antibiotics, or do we look at differential ways of doing diagnosis to mitigate this particular risk?
So basically, we first of all should see the antibiotic report, and depending upon the susceptibility pattern, we should go for the antibiotics. So as you can see in my slide, that is ciprofloxacin can be used in most of the cases. So you can definitely go for fluoroquinolones.
What should be the ideal target antigen for typhoid IgM and IgG card test? As most companies, the coding is different, like OMP, LPS, ONH antigen. I mean, there is a difference or let me say, a dispute in result interpretation. So, what would your recommendation be? As somebody who's
So because OMPs and LPS are present in almost most of the gram-negative bacteria, these form the coat or the part of the body of the gram-negative bacteria. So I would recommend that diagnosis with immunochromatography on a single sample will not suffice. You have to consider the clinical features as well as go for culture. But diagnosis with the help of immunochromatography really will not suffice. It will lead to the confusion only.
So you always recommend a mix of one or two different diagnostic
Yeah.
methodologies.
Yes. Yes.
And what has been your experience with erythromycin? Is it a kill-all drug? Is it something that we should be taking up in the, is it a risk factor that we are working with right now, erythromycin?
Sir, I'm
asymptomatic?
seeing Milind sir's question here. I
Yeah.
would like to address. Yeah, in case of Salmonella typhi, my experience is like azithromycin is only is kind of immunomodulator, but in case of Salmonella typhi only it can be used. But in case of typhoid fever, which is caused by the Salmonella paratyphi A and B, it cannot be used. So really, the azithromycin and its efficacy is doubtful, because I have not come across with it, and my experience with other clinicians and discussion with the other clinicians, they really do not use azithromycin directly. They rather go for fluoroquinolones or third generation cephalosporins, especially in case of a patient who is of OPD setting, who is walking, talking patient. So they usually go for cefixime or third generation cephalosporin in that case.
Since you're looking at the Q&A, ma'am, there's another question from Mr. Dinubandhu Nandi. Especially, I was more curious about this because we talked about using the rapid test. First, do you think it can replace Vidal? And if so, what are the possibilities or percentage chances of getting an IgM and IgG test at the same time, the same line? In many tests, we get that sometimes IgM and IgG are both positive at one point of time. So in this case, do you think it is possible for a typhoid rapid test to have IgM and IgG positive at the same time?
See, in case of Vidal and all the rapid tests, rather the immunochromatography and seeing at the Vidal and its limitation, they are almost like one and the same. So yes, IgM, if it is available, it can definitely replace Vidal. But again, I can say that only on the appearance of band at the IgM area of the card cannot only suffice the diagnosis. You have to again collect the second serum sample in the or 10 days apart or in the next week, and then only you can comment about whether it's a real infection or it's just a transient rise. Because in case of anamnestic response, there is again a chance of false positive IgM test. So the single sample is of it's actually of no value.
Well, thank you very much, doctor. You have spent a good amount of time and effort to explain this centuries-old disease to us again.
Yeah, I
And I
can
always
see.
believe,
I can see
yes,
two more questions. Yes, slide vidal and
sure.
tube vidal. Slide vidal you can do at the periphery level, where there is a lack of availability of the reagents and the tubes and other requirements which are needed for the tube vidal. Slide vidal is relatively rapid, and you can get the results within 2 to 5 minutes. But in case of tube vidal is usually you have to give the interpretation the next day after incubating the tubes overnight. And again, the Vidal principle remains the same. So with a single serum sample, you cannot really report. You have to consider the endemicity of the disease. Yeah. And the next question is, what is the possibility of getting IgM and IgG at the same time in the sample? Yes, at usually at the third or fourth month of the disease, it can be possible that you can simultaneously get the IgM and IgG. But I would like to tell you that in such situations, IgM is the winning response at the third or fourth month of the disease, and IgG can be due to the primary infection in the chronicity of the disease, or the IgG can be due to the prior infection. So mere presence of IgG cannot tell that whether it's a primary infection or the infection which has happened in the past. So yes, there is a possibility at the third or fourth month of the disease that you can get IgM and IgG at a time.
I think, thank you, doctor. You've taken the time to answer all the questions that were there right now. And we will be sending you a formal certificate of appreciation.
Yeah,
But for now,
I can see the question. I think we will take this question and then we'll go for the like.
sure,
Yeah. So
sure.
why we need biofire multiplexing despite the other diagnostic test? I mean, what is the importance? Yes, madam. So biofire, it cannot really replace the conventional methods, but only the advantage is that with the conventional methods, we actually tend to diagnose the disease after 48 to 72 hours. But whereas with the help of biofire, you can directly do the testing on the sample itself, like blood, gastrointestinal samples, for example, stool. You don't have to culture it. A stool can be directly collected and collected into that biofire pouch, and then it can be subjected to the multiplex PCR. So that is the advantage. So you have to just use biofire or other modalities just to improve the TAT and the clinical outcome. It is usually especially important in case of patients who are having serious gram negative septicemia, or who are on the verge of having severity of the disease. So it is important to improve the TAT in such patients.
One last question, I think it's come up, Mr. Rajesh Bhai. Is it possible to have para-typhi-H and BH positive in India?
Yes, para-typhi-H and BH positive in India is it can be possible because there is a vaccination against typhoid. Especially for Salmonella typhi, so actually the true infection or the incidence is rising in case of Salmonella paratyphi H infection and BH infection in India. It is again the you can say the because of the vaccination, we can see the infection of paratyphi AH and BH in India.
Because I think Dr. Jaishiram has a follow-up question to the question on the biofire. Is it the same with the RT-PCR test? I think she's asking a connected question.
Yes, madam, it is just like a multiplex RT-PCR. I mean, many of the targets are selected, like various bacteria, viruses, parasites are targeted in this particular biofire test, and then they are like subjected to the multiplex PCR. So it is similar to that. Only thing is that you can directly use the sample instead of colonies. You don't have to culture the specimen, you can directly use the sample.
Ma'am, is there any POCT test available for the diagnosis of typhoid? I think Dr. Benitis Laser has a question. Is there any POCT test available for the diagnosis of typhoid fever?
POCT, as I mean, sir, it depends upon in which clinical settings you are going to implement the test. Like at PHC level, yes, you can have again the slide Vidal and certain, you have to be dependent on the immunochromatography in that case, but provided the patient is to be called for the second sample, but which is usually not possible in such certain in these conditions. And second thing is, if your setting is hi-fi, if you can afford using these PCR based techniques, and if you have the culture and all those things in your hand, then better to go for a culture and PCR based test.
Yes, I do believe PCR remains the gold standard for typhoid testing. Blood culture and PCR remains the gold standard. But we're also moving into, I think, an era where the newer diagnostic techniques are evolving very fast. And what we have seen over the last 3-4 years, there has been a lot of development, a lot of innovation in typhoid. So even though it is one of the oldest diseases, we have had the maximum number of questions even today with a disease that I think all doctors, all technicians are educated and enlightened about, but there is still so many doubts about this particular disease. And Doctor, I think that's it. Do you have any other questions?
Yeah, if you have the availability of biofire at your setting, then it can be, yeah, it can be a point of care test in case of pyrexia of unknown origin. Definitely, you can go for collecting blood, and if the bottle is flash positive, you have to use that blood for the identification in case of this biofire.
Okay, we are running out of time now, but I think we have one more question. Okay, so the question was about how many people get typhoid fever and paratyphoid fever each year. Well, that is something that is up for
Yeah.
debate also.
Uh,
No matter,
yeah,
because
millions. I mean, millions of people can get. I exactly don't remember the number, but yeah, 1,10,000 deaths usually appear per year. Last data I have just gone through the WHO site, and I was surprised to see that even if there is a intervention with the help of antibiotics and the diagnostic modalities are so advanced, but still 1,10,000 people die due to typhoid per year.
I'm just waiting. Okay, prevention is better than cure. Can we focus on typhoid vaccination rather than curing after the disease? Is there a vaccination drive that we can
Yeah,
do?
definitely. Yeah, definitely. But I didn't highlight on the vaccination part because my topic was strictly towards the diagnosis of typhoid. But yes, prevention is better than cure. Vaccination and as well as the improvement in the sanitary practices can help in preventing the humans from getting typhoid.
I think clean drinking water is the need of the day. And if
Yeah.
we in India can move our, get our system around clean drinking water and better hygiene and sanitation, especially whether even if it's washing your hands, it can go a long way to get typhoid, put it on the back burner. Because it is still, I've been evaluating it for the last 17 years now. And I have found that typhoid, it has slight peaks and crests in terms of demand, but there is a very high incidence of typhoid throughout the year. And there were studies conducted in various parts of the country on typhoid. So certain areas, of course, have a higher incidence of typhoid, especially where rivers are used as drinking water sources. And of course, higher urban density population centers. So maybe the government has to look in that direction. But thank you for the question, and thank you, Dr. Shende, for your time. It was a pleasure
Yeah.
having you here. Uh, because the questions will continue, I know, for a while, long time.
Yeah.
So anyway, thank you, ma'am, and a small certificate from our side for appreciation. I
Thank
will have one of our team members deliver the formal certificate to you, printed and framed to you very shortly. Thank you for your time and your absolutely a lot of patience that you've had in answering all the queries and questions. Thank you, ma'am.
Thank
Thank
you.
you,
Thank you.
everybody, and thank you for being a great audience today.
Yeah. Thank you.